Hey, thanks, everyone. Hopefully you can all hear me okay. I feel like I need a guitar here to serenade you. Um, well, welcome everyone. Hopefully it's okay with the organizers that I go ahead and get started. I know we're your last panel today. I have had the pleasure of tuning in online, so I'm taking advantage of the hybrid approach here. But it's really been pretty insightful to hear from all the various speakers beforehand. And I'm a bit biased, but I have to say I'm excited for this panel in particular. I think you will be too once we get into it. I should let you know who I am. My name's Lois Pace. I am the Assistant Secretary for Global Affairs at our Department of Health and Human Services and have been serving in that role for about a year and a half. In this position, I get to see firsthand the value and the benefit of international R&D activities and investments worldwide. And it's really incredible to see the benefits that they do have, not just for vaccines, but also diagnostics and therapeutics. And so I just want to acknowledge the spectrum of innovations that are available, even though we're focused on just one today. So kudos to my colleagues who have spoken before me from FDA, NIH, BARDA, and elsewhere, as well as other parts of the US government who really do a lot of hard work working with partners worldwide to make sure these innovations are available. But importantly, is that availability and that access. I mean, innovations are incomplete without reaching the people that we're all hoping to serve. And so that's really the focus of this conversation right now. Without further ado, I will introduce our panelists. And thankfully, I think they're sitting in the order that I have on my paper, which is really helpful. But first, we have Dr. Richard Hatchett, who is CEO of CEPI, the Coalition for Epidemic Preparedness and Innovations. Hi, Richard, good to see you. And then we have Secretary Kody Kinsley, who is the Secretary of the Department of Health and Human Services in North Carolina. So it's good to see you, Secretary Kinsley. Thanks for joining us today. Seated next to Kody, we have Ambassador John Kangasong, who probably doesn't need much of an introduction, but he's our incoming coordinator for U.S. Global AIDS, our PEPFAR program at the U.S. Department of State. So it's very good to see him here in his current capacity. And then finally, we have Mrs. Denise Smith, who is the founding executive director of the National Association of Community Health Workers. And so please join me in welcoming them today. Very happy to have you all because you all bring a number of diverse perspectives when it comes to this important topic of equity and innovation and how innovations themselves can even serve to drive equity, whether that's in the government sector or outside of government, whether that's domestically or internationally, or whether it's top down or bottom up. And so hopefully we'll touch on each of those areas. But first, an opening question for each of you to respond. I really want to hear what you think has worked, what you think has worked well when it's come to closing this gap or bridging this gap between innovations and disparities or inequities. And then we'll use that to start our conversation. Maybe I will start with you, Richard.
Great. I'm just very quickly, CEPI is an organization that supports research and development. So I bring that bias to this conversation. We're also an international organization. So I would say that what has worked well throughout the pandemic is science and the scientific community, the sharing of information, the speed with which scientists and institutions pivoted to develop vaccines, delivered vaccines in record time. So the world did about as well as it was positioned to do. And I think that's an important caveat in delivering vaccines. What has not worked well is actually the topic of this discussion, which is getting vaccines to the people who need them. I would just say two recent analyses have estimated that vaccines probably save somewhere on the order of 20 million lives in the first year of their availability. But 20 million lives have also been estimated to have been lost during the COVID pandemic. And the majority of those lives were lost after vaccines became available. So we must do better on delivering to the people who need them as rapidly as possible.
Thanks, Dr. Hatchett. Appreciate you kicking us off. Secretary Kinsley.
So I think in North Carolina, what we found that really worked was being able to see where we needed to go. I think the greatest challenge we all continue to face is that we have a lot of kind of categorical descriptive information about the equity issues that we're trying to solve, but in real time, we don't have the data, the visibility into seeing it. North Carolina committed to building a vaccine registry where race and ethnicity and other demographic data was non-negotiable. We had to have that information, and then we could pair the visibility of that information to leverage, frankly, our providers and making sure that we could hold them accountable to vaccinate on par with the folks they were serving in their community. And at the same time, pair that with community-based organizations that could leverage the trust that they long had to then make that. And in North Carolina, we saw it work. We closed the gap as far as vaccinating on par in our Latinx community, our Hispanic community, and we nearly closed the gap in our Black African-American community and did close it in several age groups. We have more to go. I mean, I think the challenge we're facing, and I'm excited to talk about today, is that our health system has a long history of inequity. And when you say you have a big problem, you need to move really fast, it's not going to get better. And so we have to make it a priority to bend it just as hard as we want to move just as fast.
Thanks, Kody. Dr. John.
Thanks, Lloyd. Let me start by saying my views here will be informed by my previous assignment, which was based at the African Union as the director of the Africa's Centers for Disease Control and Prevention. So what I'm going to say maybe sounds like an odd view, but I thought that what has worked from that perspective where I sat was the ability to use inequity to stimulate a dialogue in a resource-limited setting that says we have to manufacture vaccines, regionalizing the capabilities and capacity to manufacture vaccines as a health security commodity. I think I've always, when I left my previous job, one of the things that occurred to me was that the momentum is there to regionalize vaccine manufacturing capacity. We have to build on that, but do that in a way that you create an ecosystem of how to do it right, and not if it should be done. I think that is one thing that worked. What didn't work well, as Richard said, was translating the remarkable achievement and progress that science brought to all of us to making that accessible. And that is a complicated equation that has to do with manufacturing itself, has to do with human behavior, and has to do with the timeliness of where that product gets to the intended populations.
Thanks, Ambassador Nkengasong. Please.
Good afternoon, everyone. Denise Octavia Smith. I will also provide some context in that I have been a community health worker for about 24 years. I'm a certified patient navigator. I'm a survivor of a rare chronic disease. I am someone who has experienced homelessness. I am a person who has received public assistance. It's usually common for community health workers, promotoras, aunties, our outreach workers, our peers, to ground others in our lived experience. And so I'll be sharing some of that as I provide this context. Equity is not a top-down discussion. So we have to ground ourselves when we talk about equity today in a couple of concepts that I think are well understood in this room, that the systems, the policies, many of the funding models, the services were not designed for people who look like me, for those who are poor, for those with limited English proficiency, for those re-entering society or those of different genders, for those who are immigrants, refugees, or even for the indigenous nations, hundreds of which here in this country are not recognized by the federal government, and many hundreds who are, but who struggle with nearly every indicator of health and well-being that we have. It is important to ground ourselves in the understanding that it is not just about defining equity, that equity is a moral imperative, and that when we talk about equity, it's a call to action. So in the context of vaccines, I just want to say a couple of things. Number one, I want you to think about community health workers as being vaccinated. It occurred to me that many of us have traversed and overcome many of the barriers to the social determinants of health. We are survivors of rare chronic diseases. We are persons living with HIV. We are persons who have overcome homelessness. We are persons in recovery. And in that respect, we are experts in traversing those sectorial barriers, those literacy barriers, those technology or navigation barriers. We are in fact vaccinated, but we have a commitment to go and help others, right? So what worked well? One thing that I really want to point out that is important is that in nearly every single major initiative or strategy that the Biden-Harris administration released since January of 2021, it has prioritized, it has included community health workers, right? So in the national COVID response and the preparedness plan, when we talk about mental health and in the American Rescue Plan, what we didn't do well is recognize that we needed to build not only a clinical response to the pandemic, we needed a public health response to the pandemic, but we needed the infrastructure, capacity, resource, and funding for a community-based response to the pandemic. And so with all that I've heard today and all that I'm excited about in terms of the technologies and the innovations, I don't want us to build on a faulty foundation. Community will bring these vaccines to the last mile. And further, we will make sure that the barriers to the social determinants of health do not impede vaccines getting into people's arms or through nasal or all of the other exciting innovations.
Thanks very much to each of you for getting us started. And I'm even more excited for what's to come. So I do want to start with you, Mrs. Smith, because I know something that you just mentioned about what you're hearing and how you're interpreting that. I know that you can't speak for all community health workers, right? To your point, everyone has their own experience, but I'm hoping that you can share perhaps what you are hearing from them with regards to these new innovations, if anything, right? What's breaking through and what are the things that are sort of exciting them about these prospects or keeping them up at night?
Well, you know, part of what's keeping us up at night is that the current vaccines have not gotten to everyone. We are very concerned about our children in particular, our babies, but generally speaking, we know that childhood vaccinations generally have really waned over the past couple of years. And we are seeing adult vaccinations, which have never been fantastic, also having continued barriers and just being lumped into this general sense of misinformation, right? And so a lot of our work is about dispelling myths and making sure that people have factual information to make the best decisions. But I'll tell you what is really keeping CHW or promotora leaders, those who lead organizations in the community, is that a lot of our funding for our work is actually shutting down right now. So there was a great story in March by Kaiser Health News about 400 CHWs in Chicago who had been trained, right, hired, recruited, embedded into a vaccine response. And by June, their jobs were gone. Right? That's an example of an infrastructure, dollars that are wasted, time that is wasted, expertise, relationships, partnerships, and it erodes trust in community. So what we want to do is we want to be a part of the solution and a part of this continuum from the science to the streets, if I will. And so we need that funding infrastructure to sustain these discussions.
Thanks very much. Kody, I want to come to you if that's okay. Just I'm sticking with the theme of sort of local and state level options. Denise mentioned very briefly the role of community health workers in messaging or messages. And I know that you have done a lot in the state of North Carolina in that regard. So can you give us some sort of preview as to how you would even talk about this work and maybe even blending what she just offered, right? Recognizing there's still some road to travel with current vaccines and vaccinations, and yet with others coming down the pipe.
Yeah. So I'll offer kind of maybe two examples of things we did in North Carolina and we're still sort of testing. So one is North Carolina created a counseling code as part of our Medicaid program. I believe one of the first Medicaid programs in the country to do that, and made it so that, we found that as we got through the vaccine eager into the vaccine hesitant, it took many conversations for that. I mean, sometimes it was could have been the insured Medicaid child, but it was the conversation with the parent. And so shaping the code such that we could fund that, I think to Denise's point about being able to pay for what we actually want to see. And what's interesting in North Carolina is we've started to do a cursory review of that is we've actually started to see uptake of vaccines in kids increasing while we're seeing some of that, not just for COVID, but broadly, because we see our providers really making use of that. So I think that's a very tactical example of some exciting work there. I will perhaps just go even double down on Denise's very good point, which is that we have invested so much money in community-based organizations that are doing on-the-ground work to leverage trust, to grow, to establish routine and stable communication channels, to trust folks. And, my real and tactical problem in this moment is that I want to use some of that for monkeypox, and I can't because those dollars aren't monkeypox dollars. And I think we have got to wrestle with what I call color of money problem in government. And if we're going to invest in the foundation of this on the ground stuff, we have got to sustain this over time.
Very interesting points from you both. Kody, can I ask a follow-up question of you, which is this idea of how we do leverage what's in place? I mean, do you foresee an opportunity with mass vaccinations with these innovative products, or is it your worry that you won't be able to get those kinds of campaigns off the ground in the future?
Well, I mean, I think that, when we have a whole lot of folks coming forward in that kind of vaccine eager space or test ready space, obviously these kind of mass distribution sites work really well. I mean, the kind of dollar per person operational effort is efficient and it works. I mean, of course, right now we're all pivoting towards an at-home strategy, right? I mean, we have to reduce the number of drive-up testing sites in North Carolina towards a place where we're leveraging at-home pickup sites. And we're obviously, thanks for the Postal Service and all of that. And so what I'm excited about some of the conversations about these more novel delivery methods is how can we reduce the overall burden on the healthcare system? Because the other side of this is that our healthcare providers are so tired. Everybody is spent. Our workforce is incredibly drained. If we can try to minimize the impact in those spaces safely, I think that there's a lot of promise for some of these more novel delivery mechanisms. But we have to think about that kind of end-to-end effort that it will take to do that.
Thanks very much for taking that follow-up. Dr. John, I want to come back to you actually on this topic of how we innovate the delivery, right? And reduce the burden on healthcare systems, not demand so much of the systems or the citizens for that matter. I know that you in your current role are overseeing the US's global AIDS programs. And a lot of that work through our President's Emergency Plan for AIDS Relief, a lot of that work has been leveraged in the global COVID response. So what's your take on how we can worldwide ensure the delivery of these new vaccines, especially given your experience in PEPFAR and new innovations for HIV?
No, absolutely. I think Denise and Kody also touch on this. Delivery will always be human capital related. And that will require that we leverage on what is already available. When I hear discussions about pandemic preparedness and response that hover around creating some new mechanisms on to put assets together, I said that in my view is the wrong way to go. I mean, we should be looking at how platforms that we have invested over decades, like the PEPFAR platform, can be elevated and used more appropriately to deliver. which is essentially supply chain management issues, workforce issues, information system issues, which already exist. And PEPFAR did some of that, quite a lot of that during to support many countries in Africa, where you saw vaccination rates for COVID increase significantly when those platforms were appropriately leveraged. I think that those are the kind of things that we should be looking at, including community healthcare workers that played a very important role, including during the early phase of the COVID response, where we just didn't have vaccines. It was, we were fighting it with a very basic public health measures, which was test and trace. And you deployed at that time, I recall, using about 20,000 community healthcare workers. South Africa did that very successfully. And most of those community healthcare workers are those that had been trained on HIV. So I think the task ahead of us here is really not to create entirely new systems, because they will go to waste. But to leverage a system that are already being used. I think that is very, very important. So I'll just end by saying that elevating these platforms that we've all known that deliver in a very impactful manner is the way to go, not just for PEPFAR, but the Global Fund as well.
Well, thanks very much. And I see Denise nodding along, so it just shows the synergies here. Richard, I want to come to you because I've heard you talk about the importance of inserting equity at the beginning, right? And I know that the work of CEPI is really focused on that, really looking at the pipeline from the start. So can you explain how that's getting inserted into how you make your investments and decisions?
Yeah, no, thank you. Thank you, Lois. I was actually eager to make the observation that, here we are talking about equity at the end of an interesting day. And, but that's not how we should be thinking about equity. We should be starting with equity. Equity is not a discrete goal that can be attached on to other discrete goals. It has to be a mindset, and preparedness actually also has to be a mindset, and it has to inform all of the decisions that you make. Just to illustrate a little bit about what that meant in terms of CEPI's response, our institutional response. CEPI was created to support vaccine development. We were actually created to address epidemic diseases. Initially, we weren't considered to be a pandemic response organization, but when COVID emerged, we jumped in. And we jumped in by moving fast because we were concerned about the potential for global spread. But we also were concerned about equity. We anticipated, based on our experiences during the last pandemic, which in 2009, which fortunately it was a very mild virus, but the potential for global catastrophe was large because we did not achieve equity. And we did not distribute vaccines globally until quite late in the pandemic. So as we began to gear up to develop vaccines, we actually wrote into our R&D contracts requirements for equitable access. And we actually envisioned, with our colleagues at Gavi and WHO and ultimately UNICEF, envisioned a global allocation mechanism which became COVAX. And even before COVAX existed or had a name, we were writing contracts that were requiring our partners to make doses available for the global allocation facility. And I would just say that the root causes of the inequity that we experienced in 2021 in particular, after vaccines became available and before supplies became robust, were manifold. There were things relating to the technology. I mean, cold chain requirements for the vaccine were an issue. There were institutional causes. There were financing causes. There were structural causes. I would say John mentioned the way vaccine manufacturing is distributed globally. And to address equity as a whole, we have to bring an equity mindset to thinking about each layer of those problems, both at the sort of holistic international level, all the way down to the delivery and breaking through these barriers that specific communities or subsets of communities may encounter. And so that is how we at CEPI have incorporated this idea of sort of equity first, and then make decisions that lead towards that goal.
Thanks, Richard. I'm hoping I can ask you a follow-up question as well, which is whether or how you all, as part of discussions around COVAX or the broader ACT Accelerator, how you all are thinking about next generation innovations and how that applies to what's been established or what's to come.
Well, so COVAX is the international mechanism for procuring and taking vaccine donations and then delivering those globally, just for anyone who's not familiar with it. There were a tremendous number of innovations, that ad hoc innovations, essentially to solve problems in real time as we went along in terms of procurement, structuring advanced purchase agreements, setting up a global liability and indemnification system and a no-fault compensation system that facilitated rapidly, making vaccines available in different countries and different legal environments. We've developed an inventory of those innovations, and again, they are manifold across different domains that had to be addressed for COVAX to operate. And we've thought about which of those innovations are sort of intellectual innovations that you can, as the pandemic winds down or as we shift into a different mode, how you can bundle those up and have them kind of waiting to be called out again. I mean, one example would be the allocation framework that WHO developed. That's something that in a future pandemic, we could bring down as a place to start. Other innovations or other areas where innovation is required, where we ran into really significant challenges, are going to require ongoing work. Financing is one obvious example. Some of that work has already begun. The last area are innovations that actually now need to be embedded in day-to-day practice and in day-to-day delivery and day-to-day communication with communities. And so we've begun to think systematically about how we can capture the innovations, but also the lessons learned, and then think about how we can make those sustainable for the long term.
Thanks very much, Dr. Hatchett. Okay, back to you, John, because you are doing a lot and have done a lot in terms of rallying sort of this leadership at a regional level. And so I'm also wondering what you're thinking about these innovations and how, in particular, not just global platforms like COVAX, but regional platforms such as what's come together through the African Union or other parts of the world can also best take advantage of these new products and technologies.
Absolutely. Let me just reflect a little bit on COVAX, and then I'll segue to the regional question. At the height of the pandemic, I thought COVAX was one of the greatest innovations in recent times in global health that are equate to the innovation in Global Fund, the establishment of the Global Fund. It was one of the greatest, the greatest good intention to solve a global problem collectively. And it also represented, in my view, a great symbol of solidarity and cooperation. But how that intent and all these things translated into practicality were challenged. I think we should also learn from that. And challenged not because of COVID, but because of externalities that surrounded the whole. So we should build on that and try to fix it, and look at it in a holistic way. And this is where I segue to the regional platforms and truly have a mindset that listens. A mindset that listens to the regional aspiration of what different parts of the world are trying to do. As we speak, the ASEAN countries are establishing a public health agency. What the PAHO, the Caribbeans, the African regions, the Gulf states are establishing a CDC. So that says something that we should be thinking of our global health security architecture at three levels. I mean, what do we do globally? What do we do regionally, and what do you do at national level? That is a collection of that network that will give us that health security, the instruments that we are looking at. When you look at regionally, at least from where I just spent 2.5 years until last April, the continent of Africa rallied around the political leadership and goodwill and said, look, despite COVAX. We're going to create an African vaccine acquisition platform and secure 400 million doses of vaccine. That is not opposed to the central COVAX mechanism, but rather complementary. That those are kind of things that you need to encourage more. We need to encourage more. And as we think of the next generation vaccines, begin to see how those platforms that were put in place regionally can enable us to leapfrog any challenges that were observed during with the issues with the first generation vaccines. Let me just say this, that in Dr. Fauci's opening statement, he talked about leveraging the HIV, that some of the advances that we saw in HIV, in the COVID vaccines were because of the networks that we have established from HIV. It's also true as we regionalize and begin to mitigate the risk of putting all our eggs in one basket. I think that is exactly what we should be looking at. How do you learn from the experience in a positive way, okay, and have the courage of saying there were some gaps that occurred. We should build on those gaps to strengthen our collective security apparatus, including support of the regional initiatives.
I'm curious from you, John, before you turn off your mic, how you're also thinking about opportunities for regional manufacturing. These are investments that even the U.S. has made alongside other countries. I think to your point, there's an opportunity, obviously, to ensure the Africa region, for example, can directly procure these innovations for themselves. And as you said, sort of leapfrog the process. But then I think there's another step with regards to whether or not these products can be developed on the continent outright. And I see Richard nodding too, so I'm happy for you to come in after John as well.
No, it has to be regional manufacturing has to rely on two things: that it is a political decision, that not an economic case for investing in regional manufacturing. That says that if we do this right regionally, it helps in the global health security space. And as I said earlier, and I see a lot of people in this room have been following the discussions around regional manufacturing, that it is no longer acceptable, at least from the conversations I'm hearing from around the world, that certain parts of the world would just wait for vaccines to be manufactured elsewhere and then they consume. Because as we have seen in the COVID pandemic, when commonly challenged, people don't fold inward because they hate other people. It's just because of the scarcity of that commodity. And I think we have to acknowledge that when faced with a common threat, the reaction, as when we all get into those planes and the pilot or whoever says, well, put on, in case of any oxygen shortage, put on your mask first before you put your child's own mask. It tells you what a common threat looks like. But we can work on that common threat now that we've learned lessons from it and say, let it be a political decision that we all say that we have to do that. Second, and lastly, is that we have to admit that we must focus also on behavioral and social science, because we've seen how even when those products are available, there's a value of that to cross before you get the vaccines into arms. I think, and it's not only true for COVID. I mean, I've been to DRC about 6 times over my last 5.5-year stay, and you think, well, we have vaccines for Ebola, you go to North Kivu with that, and people will take it. No, it's not straightforward. I mean, you have to have community leadership, owning that process, understanding that. So I'll just end by saying messaging early and messaging frequently is a cornerstone, or what I call the ingredients for a trust capital that we need in the community to cross that gap between availability of those products and access to the products in the community.
Oh, I really want to get into that uptake piece for sure. Richard, did you have anything to add quickly before then?
Yeah, just very, very quickly. I mean, I think looking at it from a global perspective, one of the most important causes of the inequity that we encountered, I mean, the root cause is scarcity. And while you have a period of scarcity, you're going to have the kind of dynamic that John describes. But one of the most important structural causes of inequity is the way vaccine manufacturing is currently distributed. in a few locations with large populations that will have to be served first. And so one of the initiatives that we've undertaken with the National Academy of Medicine and also with the World Economic Forum is to set up a cross-sectoral group called the Distributed Vaccine Manufacturing Collaborative, where we're going to look at issues relating to financing, to business model, to technology, to workforce development, to try to inform these efforts to expand regional manufacturing. It is not going to be easy to have globally distributed manufacturing, but it is critical to health security that we succeed. And so this effort brings together economists, it brings together political leaders. John's participating in it, non-governmental organizations and the private sector who will make critical contributions to try to bring that collective understanding together to think about how we can rapidly advance regional manufacturing efforts.
And keep it warm, right?
Yeah.
So that you can turn it off and on.
Well, and it has to be sustainable. It cannot be something that is mothballed and then work when you need it to. And so there are questions around market shaping and market creation that are going to be important. One thing that we have done globally for the first time ever is try to reach adult populations with a life-saving vaccination. There are many, many countries that do not have adult vaccination programs at all. We should use COVID as a beachhead to build out adult vaccination programs, and that will provide many, many benefits beyond just delivering COVID vaccines.
Thanks very much. I want to come back to you, Kody, and then you, Denise, as well. And also say that this is a question from the audience. So thank you for submitting those. There is this question about how we improve uptake of vaccines, but also how we balance efforts around COVID with other vaccination programs. And I think what we saw in the States, but especially around the world, is the need to get that balance right. And I was hoping you could speak to that.
I kind of want to comment on the conversation and
Comment on whatever
question.
you'd like.
So, I think that, and I know this is a summit on vaccines, but I think it's really important that we continue to remember that there is not a real silver bullet, right? That we're in complex disease management. And it's going to take every tool and an equitable approach with every single tool. And I think that perhaps the best thing that we can really do to continue to center equity in readiness around supply chain readiness and everything is to build more trust in the healthcare system that we have. My personal story, I grew up in North Carolina without insurance. I was 25 before I had health insurance. And had you told 24-year-old me, don't worry, testing's free, I would have said, yeah, right. We have built an expectation among our citizenry and the residents in our country that the healthcare system will work for them. And I think we've got to change the game there around everything if we hope that for every vaccine or anything we want to do, it is going to be available. I think that, what I am worried about as a health secretary is that we have gone through this really galvanizing moment around vaccines, and we're now seeing people opt out of vaccinations more than we have before because of this political, kind of questions that have arisen in there. And I think we've got to get back to the basics, bring down the temperature, and really try to localize the conversations. So I go back to things like funding, counseling codes, to being a part of the normal patient-doctor relationship, supporting community health workers and other on-the-ground workers to have those conversations. I think we've got to get the conversations about vaccinations less coming from people like me and more coming from trusted resources locally. I think that's what really matters moving forward.
Thanks very much. Denise, what are your thoughts on this question of uptake and balance?
Yeah, and I want to go back to this idea of building a community-based infrastructure, because a lot of the comments I was just sort of circling, yes, we need that. Yes, we need that. Community health workers, our definition from the American Public Health Association, which has been around for over 20 years, embeds the word trust in who we are. And it's really important. I was having a conversation with someone early in the pandemic and just talking about, at that time, trying to get any money, grant funding for the work that we do. Most CHWs are working in community organizations and not hospitals or health plans or FQHCs, but we're working in nonprofits or CBOs. And someone said something to the effect of like, well, that conversation won't work in a red state or something like that. And I thought, I don't think you know who community health workers are, right? Community health workers are your health ministers, right? They're the natural helpers in literally every community, every culture, every faith, every geography, right? And it's not, what's beautiful about being the ED of the National Association is I get this rainbow coalition of people who are organized around our values. We want all people, but particularly people in our community, to have access to high quality, culturally competent, effective healthcare so we can go on and live the lives that we want to live. And so when I visit our members, I'm in Kentucky, rural Kentucky, and in Ohio, and I'm in LA, and I can be anywhere and find this frontline workforce. But if we don't build the infrastructure, and we've seen this happen before, we've built it. I love this mothball idea because we've done this before where we scale up and we ask everyone to, roll up their sleeves and support. And then when we have a sort of modicum of success, oftentimes it's the lowest hanging fruit. Now we think that we can retreat or move on. And so again, this issue of equity means that we are always going to have high risk populations, people who fall through the cracks, who don't have a primary health care provider, who have Medicaid but don't know how to use it to prevent disease or hospitalization. So there are things we have to do to build the infrastructure. Globally, we have to pay community health workers. And I would implore everyone who envisions CHWs as part of your delivery system to find CHW programs and CHW-led organizations across the globe and invest in them. We don't have federal legislation right now in the United States that even defines who we are as a profession. And this is after decades of evidence of our effectiveness. We even have a Department of Labor classification, but employers often don't use it. So we have hundreds of different work titles, and it's very difficult for people to understand who we really are. So we have to acknowledge the workforce as frontline, moving upstream, trusted, with deep relationships, culturally appropriate, linguistically relevant, and we have to pay them, right? We have to prioritize CHW's vaccinations. Why? Because we leverage our lived experience. And so when I'm vaccinated, I am already trusted within my community, and I'm able to go back and say, girl, it wasn't nearly as bad as I thought it was going to be. My arm hurt for about 24 hours, and I laid on my couch, but I feel great. And now I'm protected. And I'm doing the things that I want to do with my family. We need education on these innovations, right? So I'm eagerly waiting for emails from all of the pharmaceutical companies who want to reach the frontline workforce, because you're going to help us develop curriculum and training programs so that we don't have to wait to try and find the information online and then try and translate that. You're going to work with us to develop that curriculum as close to real time as possible so that the frontline workforce is ready with that messaging. We don't have to wait 2 months to translate into Spanish or Marshallese, right? Or Farsi. We're going to be ready with those innovations. We need to develop communications with CHWs. We know what communications work with youth populations, with reentry community populations. We know how to find those who are experiencing houselessness, et cetera. And then finally, we need to coordinate on strategy. And this is really important because from the early months of the pandemic until now, we are often seen as downstream actors. So people want us to distribute flyers, perhaps, or they want us to knock on doors and tell people where the mass vaccination site is, but they don't want us to upload what we know about the barriers that already exist in community. And I'll just give you one quick example. About 2 weeks ago, I was in Hawaii with Papakulea Homestead. They are a Native Hawaiian CHW-led organization. And this summer, they are training youth to conduct a senior assessment because they've been pushed from the ocean side up into the mountains. And most of their elders live in houses that are like on stilts. And so it's very hard for those elders to leave their homes for food, for their pharmaceuticals, right, to access medical care. So there are real strategies that you can upload from local or hyper local organizations. And these are, sort of some of the things that we do. Sometimes we do it successfully. I don't want to say that it's all sort of doom and gloom, but we need to scale up, right? What's happening in North Carolina, what's happening in other pockets across the country or around the world.
Thanks very much for that. You went ahead and answered the other audience question that I had, so appreciate that too. It was really, really wanting to dive more deeply into community-based funding. And so I think if we were to ask what you would do with additional funding, we already know based on what you shared, and there's probably a lot more to come from that. I'm hoping that as a closer, we can hear from each of you what you would do if there were a new innovation, a new vaccine to come, in the next 30 days, right? What's the very first thing that you would want to make sure happens that's under your control or under your purview to be ready for that innovation? And I will keep you on the spot a bit longer, Denise, and work my way back down the panel if that's okay.
Yeah, sure. As I said, most CHWs around the globe are not paid to do this work. And while we want folks to get paid, we know that they are going to roll up their sleeves and do the work that needs to be done to protect individuals and families in their community. And so the first thing that we would do is just make sure that we had methods to educate. Sometimes we have to do it via Zoom. Sometimes we have to email folks something. CHWs have been training one another over the phone, right? Hundreds of CHWs were trained by the Florida CHW Coalition, literally on conference call only, because folks didn't have internet access. So what we would do is disseminate the educational information, answer questions, try to dispel myths, and give people tools in diverse languages so that they could inform their community about a new innovation or what's to come.
Thanks very much. John, what's your first step?
Very quickly, I think I will end with where I started, which is focusing on regional or decentralizing vaccine manufacturing as one way to unlock the inequity or address the inequity problem, but do that in a way that is coordinated and is an ecosystem around it. So that not everybody is doing the same thing at the same time. Then anchor that onto the challenges that are existing in the region. So what are those diseases that are already prevalent in the region, so that manufacturing is not just looking at the COVID vaccine, but manufacturing of what vaccines will be required in that region. Because today is COVID, we don't know what will be tomorrow, but the anchor of that should be on addressing the prevalent diseases that are in that region.
Thanks. Kody.
So I think if in 30 days, one of these innovative products were to come out, then I think a year and a half ago, we needed to start talking about it.
It was a trick question, wasn't
I
it?
saw, and I think that's the challenge. Why I'm so glad that we're having this conversation today is because there is a tension between obviously novel, new anything, but yet building trust over time in the communities that we are serving to be sure that when we're ready, they're also ready. And I think we have to do that now. I think it's particularly the challenge for us in the moment, and we're all going to work together on is, how do we also do that in the context of everybody being frankly incredibly weary, tired, mental health crises across the country. We've got to start to figure out a way to build trust now. And I am a dog lover, but build trust now using different methods of vaccination and what that's going to look like. And I think this is the hardest part, trying to be incredibly clear about the value proposition, because I think from the beginning, there's been a lot of hope about the value proposition of this is what's going to end it. We can move forward. And that hasn't exactly followed through. We've got to rebuild that trust.
Yeah, it comes back to that messaging or education or communications that Denise was talking about, but
Absolutely.
readiness and weariness. I'm taking that with me. Richard, last word.
I'm going to give a quick two-part answer.
Sure.
The first is if in 30 days, I think the single thing that we could do to improve global equity, our industry partners have put together something called the Berlin Declaration. They have said that they will reserve capacity for global equity, but they need countries to step up and provide funds to provide for advanced purchase agreements to allow them to do that. That is an offer that I hope governments, the G20, the G7, will follow up on. The second piece, I haven't talked a lot about technology, but CEPI is a technology organization. John made the point that inequity derives from scarcity. If we can accelerate vaccine development, countermeasure development, Ashish and I think Tony spoke about the 100-day goal, we can reduce that period of scarcity. And so making major investments, again, across the G7, across the G20, to develop the capability to rapidly deliver countermeasures when we need them will fundamentally change the equity equation.
Well, there's your answer. Thank you all very much for all your insights today. We really appreciate it.
All right, we're near the end here, folks. If I'm back, thank you all for sticking through what I think was a really fantastic day. I watched a good chunk of it from my office as I was running back and forth and caught glimpses of what I thought were the kinds of insights and conversations we needed to be having today. And I'm sorry I couldn't physically be here. I do want to just give one quick update. For those of you who I know it's been on everybody's mind, the president had a chance to connect with him. He's doing great. Today is day 5 of isolation. His symptoms are largely resolved at this point. Still has a little bit of a raspy voice, which may last days or weeks, but he is otherwise feeling very well. And it's really actually quite a remarkable testament to the vaccines we have. If you remember this morning, I started off saying our vaccines are terrific. We have to do better. Still believe that, really believe that after listening to today's conversation. But it is important to remember just how remarkable it is that SARS-CoV-2, a virus that I think rightly caused a lot of concern, a lot of fear, and getting infected for many people, unfortunately, more than 1 million Americans, meant something, really terrible outcome. We're at a point where if you are vaccinated, if you're immunologically up to date, now obviously he was also helped by an oral antiviral on top of that, which is again available broadly, but really quite extraordinary. I want to take maybe 3-4 minutes just to wrap us up, based on, again, the things that I heard today, and I apologize if I missed some important points. This is not going to be comprehensive, but both from panel 1 and 2, but particularly in panel 1, it struck me that so much of the conversation focused on the power of public-private partnerships. I often talk about, when we think about what the country accomplished in 314 days, there was no way that we could have pulled that off without an active role of government. And so for those people who believe in the power of government, there's a great testament and a great sign of the power of government. There was no way we could have pulled that off without both the innovation and the capacity and capabilities of the private sector. And for people who believe that the private sector has an incredibly important role to play in major societal crises, Operation Warp Speed was a great testament to the power of the private sector. But the real answer is and by the way, and collaboration among scientists domestically and globally, the real answer is there was no way any of those entities could have pulled it off without collaboration. So it is not just that each of them were individually critical, but it was how they interacted together that made a difference. And I think the power of that and trying to think about how do you harness that at a different time. We don't have the same level of crisis, Not saying COVID is over. COVID continues to be a substantial problem, but we're not in that same level of crisis. And so how do you harness the power of that public-private partnership? I think there were some very good ideas, but I think we need to make sure that continues. I think both in panel 1 and panel 2, you heard a lot about the power of the transformative power of these new generation of vaccines, whether they are ones that are going to provide much broader protection, they're going to provide blocking of transmission, reducing infections. And you also saw companies large and small and the progress that they are making. That these things do happen, that there's been a lot of work. You saw Tony talk about investments of the NIH, and then obviously investments in the private sector. We are making serious progress along the way. So I think that is critical to understand. I also thought it surfaced a lot of issues that is work for us in government, in this administration to do. I'll just say a couple more things. Panel 3, I love the line of vaccines as a kind of great equalizer. Obviously, there are critical issues of making sure that vaccines are allocated equitably, but they really do have this transformative power, not just of saving lives, but of reducing inequities in our response. If you think about if we did not have these incredibly safe and effective vaccines, the huge inequities we saw in the first year of this pandemic in the United States, I think would have been much, much harder to close without vaccines. Again, those inequities are not gone, but they are clearly better in year 2 for 2 reasons. One is this administration made equity a central goal, and we've worked on it on vaccinations, on boosting, on therapeutics. But vaccines, when deployed widely, can be a great equalizer. They can help